It's my pleasure to introduce our next speaker, Dr. Angela Fleischman from the University of California in Irvine, who is going to talk to us about inflammation and MPNs. Angela.
Thank you very much, and it's very difficult to follow the illustrious Dr. Silver, but I'll do my best here. So today I'm going to be talking about inflammation in myeloproliferative neoplasms, as well as some approaches that we've been taking lately to try to reduce inflammation in MPN through potentially through diet. So when we talk about inflammation, you hear a lot about inflammation these days and its importance in lots of chronic diseases. But what exactly is inflammation? I'll be discussing why it's important in myeloproliferative neoplasms, and then touching on a little bit about how we can potentially reduce inflammation, ideally through low-risk, low-cost ways. So what is an inflammation? Scientifically, when we talk about inflammation, we talk about these hormones or proteins called cytokines, which our immune cells produce to help us fight infection. So inflammation is critical when you need it, such as in terms of an acute infection, but inflammation is bad when you don't need it. And chronic inflammation in the extreme senses can cause things like autoimmune diseases, but we do know now that chronic low-grade inflammation can underlie a lot of chronic diseases such as atherosclerosis, and so really does have widespread implications for human health. So inflammation has been known to be elevated in myeloproliferative neoplasms for some time, and these are all different inflammatory cytokines that have been found to be elevated both in mouse models of MPN as well as in MPN patients. And you can see that a lot of them are in common. So why is inflammation high in myeloproliferative neoplasm? That's actually a very good question that we have some ideas, but clearly don't have everything defined at this point in time. So we've heard a lot about today JAK mutations, which are involved in a JAK2 mutation activates JAK-STAT signaling, and JAK-STAT signaling is important for cytokine signaling, which can tell our immune cells to make inflammatory proteins. So it makes sense that an activated JAK2 could make a cell overproduce cytokines. But that may not be the whole story. I personally believe that a chronic inflammatory environment likely precedes the development of a myeloproliferative neoplasm and could play a discrete role in disease progression. Also, another interesting observation is that although mouse models where we induce a JAK2 mutation do have some evidence of increased inflammation, the amount of inflammation that we see in MPN patients is really quite much more robust than what we can induce just simply but with JAK2 in a mouse model, suggesting that there's something more that's in these MPN patients that we're not recapitulating in our mouse models of MPNs. So this is just a primer on JAK2's role in the blood cell development. So in addition to production of red blood cells and platelets, which also use JAK-STAT signaling, also cytokine production uses JAK-STAT signaling, and different sort of combinations of JAK and different receptors can sort of personalize sort of signaling pathways. So you've got a lot of mixing and matching going on with JAKs and STATs to produce particular programs in particular cells. So under normal circumstances, a normal JAK in a cell is only turned on when the cell sees particular growth hormones, such as erythropoietin, that makes you make red blood cells, and turns JAK2 on. But with a JAK2 V617F mutation, what happens is it changes the JAK2 protein such that it's always on. So that's why the cells are always thinking that they're getting the hormones, such as erythropoietin or thrombopoietin, to make them produce more red blood cells or platelets. And that could also induce cells to produce more inflammatory cytokines. And we do know that MPN patients clearly have a very heavy symptom burden, and different MPN patients can have different symptoms, and certain inflammatory cytokines have been, I think this is overstepping saying drive specific symptoms. I guess a better statement is correlated. Specific symptoms are correlated with elevations in particular cytokines. And chronic inflammation can cause bad effects in terms of the body, but chronic inflammation can also have some significant harm to blood stem cells or hematopoietic stem cells. We do know that in disease models, if you induce chronic inflammation, for example, in mice, I know I'm talking a lot about mice, but that's a model that we use to sort of recapitulate humans, that we can cause stem cell exhaustion, meaning that their blood stem cells basically poop out when we give them chronic inflammation. So it's conceivable that in humans as well, chronic inflammation throughout one's lifetime could lead to basically stem cell aging. And interestingly, many of the current treatments that we have for MPN modulate inflammation. For example, aspirin, which patients primarily use for the purpose of reducing the risk of blood clots, can also have some anti-inflammatory properties. Interferon is an immunomodulator, would not necessarily say that it reduces inflammation, but is an immunomodulator. And interferon actually is a normal cytokine that our bodies make in response to infection. And then JAK inhibitors, interestingly, are quite strong anti-inflammatory drugs, and JAK inhibitors are also used widely in autoimmune diseases. So there's a lot of commonalities between MPN and autoimmune diseases, in particular in the common use of JAK inhibitors. I'm sorry. So how can we control inflammation? Like I just mentioned, can use prescription medications such as JAK inhibitors, which are strong anti-inflammatories. And a particular area of interest of mine is utilizing lifestyle approaches to help minimize inflammation, with the understanding that there is a limit to what lifestyle approaches can do. I don't want to say that they can cure the disease, but I think definitely there are things that patients can do with regard to lifestyle modification that can definitely benefit their health and reduce their inflammation. And this is particularly important for an MPN patient population in whom have chronic inflammation. So we do know that maintaining a healthy weight can reduce inflammation because your adipose tissue or fat tissue increases inflammation. And there are known benefits of healthy lifestyle, including diet, exercise, and stress reduction in terms of reducing inflammation. So we wanted to think about ways that we could modulate symptom burden, which has a major impact on the quality of life of MPN patients, that as well as could potentially prevent disease progression and are low cost and low risk, which is the key. So that's why we thought about diet. There's, diet, incorporating a healthy diet into your lifestyle in no way could be thought of as controversial or have a negative impact on a person's lifestyle. So thinking about what type of diets would be most appropriate for an anti-inflammatory diet, we turn to a Mediterranean diet, which is widely regarded as a general healthy diet, as well as there have been large studies in large cohorts of patients in cardiovascular disease, demonstrating the benefits of a Mediterranean diet. it was able to demonstrate a reduction in biomarkers of inflammation. So we thought that because myeloproliferative neoplasm is also a chronic inflammatory disease, it might be useful in this patient population to incorporate a Mediterranean diet. So what are the key components of Mediterranean diet? Rich in fiber because it has lots of whole grains, fresh fruits, fresh vegetables. Reserve a lot of the foods that are incorporated into a Mediterranean diet naturally contain natural antioxidants such as resveratrol and monounsaturated fatty acids, because primarily the fats that come in the Mediterranean diet are good fats from olive oil. So our hypothesis or thought was that following a Mediterranean diet might reduce inflammatory cytokines in MPN patients, relieving symptom burden, and potentially blunt their disease trajectory. So at UC Irvine, where I'm located, we've performed 2 dietary studies thus far. And I want to emphasize that the purpose of these 2 studies are for feasibility, not necessarily to demonstrate a clinical impact, but simply to demonstrate that if we give MPN patients a intervention by giving them education and dietitian counseling, they are able to change their diet. So the first initial pilot study, we compared a Mediterranean versus just a standard U.S. guidelines for Americans diet. We enrolled 28 patients. They had in-person dietitian counseling. They were also sent weekly PDFs of information about a Mediterranean diet. We collected their blood counts, their chemistries, some measures of biomarkers of inflammation, for example, CRP and their cytokines. We also were interested in their gut microbiome. And then the second diet was a fully online diet, which was done in the setting of COVID. So we were limited, so it had to be fully online. And in this, we compared Mediterranean versus DASH diet, and this had Zoom dietitian counseling. And our biological samples were limited to things we could collect in the mail. And so initial pilot study, basically, we followed people for 2 weeks, just basically to see what they were doing at baseline in their normal habitat. We collected blood and stool and then did 2 surveys of symptoms and asked what they were eating. And then the intervention period was a 10-week intervention period where patients were given in-person dietitian counseling. And then we also, the larger Mediterranean diet studies in cardiovascular disease gave people olive oil. So we did that as well. And then this group got coupons or gift cards for a grocery store. And then during this, we collected 2 samples of blood and stool. And then this last time period was the follow-up. Basically, people were no longer given dietitian counseling or they weren't, or written curriculum, but we continued to follow them for a few more weeks. And so to reiterate, the main point of the study was, can MPN patients change their diet with dietitian counseling and curriculum? And so there is a 14-point questionnaire called the MEDAS, or the Mediterranean Diet Adherence Score, which is a validated score which gives you a score of how adherent you are to a Mediterranean diet. And a score of 8 or greater is considered to be adherent to a Mediterranean diet. So our goal for this study was to see whether the Mediterranean diet group, we could get at least 80% of them having a MEDAS score of at least 8 during the active intervention. And that's the pink group. And we were able to achieve this at the last 12-week mark. We actually 78%, which was slightly below our predefined goal of 80%. But in contrast, the patients who were getting just the standard U.S. guidelines for American group, at no time point did we have 80% of them getting a good adherence to a Mediterranean diet. So this is really demonstrating that MPN patients are able to change their diet towards a Mediterranean diet eating pattern. Although the study was not what we say powered to detect a change in symptoms, We measured symptoms, and as with many MPN studies, these are waterfall plots where each bar is a specific patient, and this is at different time points during the study. And a bar going down means that their symptoms went down. Going up means their symptoms went up. And as you can see, both groups, the Mediterranean diet group and the USDA group, there were a good fraction of patients who had a reduction in their symptom burden, but it appeared to be more robust in the Mediterranean diet group. Now, it makes sense that any improvement in one's diet would make you feel better, but potentially, specifically incorporating foods in a Mediterranean diet could further enhance this improvement in symptoms. And we want to know whether there are specific symptoms that might be changed with a Mediterranean diet. So we parsed out each specific question on our Mediterranean symptom or our MPN symptom assessment form, and did not have any specific symptoms that were popping out as specifically affected by a Mediterranean diet. We also wanted to see if there was a correlation. We want to observe correlations between on the right axis or the x-axis is their Mediterranean diet score. On the y is their symptom burden. So if they changed, basically wanting to know if they changed their diet towards a Mediterranean diet, were they more likely to see a reduction in their symptom burden? And other things that we measured in the study, we measured blood counts. We were not necessarily expecting to see changes in these things, but we wanted to observe them for information for subsequent studies. We looked at cholesterol, looked at high sensitivity CRP, inflammatory proteins in the blood, the cytokines, as well as the gut microbiome. And then we were also able to get specific things that people were eating, because we did this ASA 24, where at certain time points during the study, patients reported exactly what they ate over a 24-hour diet period. So we had exactly every single thing that went into their mouth during a 24-hour period, so we could get calculations of specific components of their diet. And it comes out with, reports sort of like this. The diet was not meant to be a weight loss or a weight gaining diet, so we weren't counseling people on calories, but there was not a significant change in the caloric intake of both the either of the diet groups, as well as not a significant change in their weights. And because fiber is a key component of a Mediterranean diet, wanted to look at specific things that they were incorporating. Changes in fiber intake both diet groups had an increase in their fiber intake. And then inflammatory cytokines, we looked at a panel of different inflammatory cytokines. And again, given this small group, we're not necessarily expecting to see any changes. It was simply to observe, to help us design further studies, and did not see any significant differences or changes in the cytokines during the study in either of the groups. Also interested in the microbiome in MPN, and we'll hear later today more on this topic from Dr. Hasselbach. So we collected serial samples throughout the study to look at the gut microbiome. So each person had 4 samples, so that gave us a total of 103 samples that we looked at. Let's do this one first, and I'll go back. And the microbiome is a very personalized. So my microbiome is very different than yours. So and each person is very different. So it's very difficult to make discrete conclusions. This is just a visual representation of the different bacteria that was made up each person's gut, and each of these is a single person. And you can see from the colors that this person really looks a lot more like himself or herself throughout time versus this person. There are some subtle changes over time, But no, we were not able to parse out very specific changes that came with either of the diets. But an interesting another feature that we were able to parse out, because this diet intervention had both PV, ET, and myelofibrosis patients, we were able to detect some differences comparing myelofibrosis versus the PV and the ET patients. And in the gut microbiome, you want your gut microbiome to have lots of different types of bacteria, as well as you want it to be even. So you don't want to have a predominance of one bacteria over the other. So that's called evenness and richness. So you want to be even and you want to be rich in your microbiome. But interestingly, the myelofibrosis patients had less evenness and less richness in their microbiome compared to the ET and the PV patients. Now, what that means is unclear. It could be simply a reflection that the myelofibrosis patient population has a more severe disease, and so their microbiome may also be a little bit more abnormal. Or it's intriguing to think that maybe this deranged microbiome could be playing a role potentially in myelofibrosis. And so quickly, just moving on to the second study, which was a totally online study. We call the e-intervention. Similar setup, but we were doing Zoom-based dietitian counseling, and everything had to be done online, including sample collection. In our sample collection, we chose to use this oral mucosal transudate, which people could collect in their home, which you have this little pad that you put next to your teeth, and is supposed to be basically a transudate that's sort of equivalent to blood plasma. However, realistically, there's no great alternative to blood for cytokine analysis. So for this, our purpose was asking whether, we had many of these patients that we had never met physically. They had really no, if they fell off, if they stopped responding, we would have no way of sort of capturing them. So we wanted to know, are people going to continue to stay involved in a 12-week study here where we're asking them to do a lot of things? So amazingly, in the Mediterranean diet group, so we asked patients to complete an online symptom survey every single day for 112 days. And amazingly, in the Mediterranean diet group, almost 100% of them, they almost had 100% compliance, where the DASH group had a little bit of a less compliance. And so this was the number of weeks that they completed at least 5, and this is their total, the percentage of the total. So the MPN patient population is quite impressive in terms of their ability to continually engage with daily surveys. And then here is the on this graph is another waterfall plot looking at symptoms, and both groups did have a percentage of patients that had a reduction in their symptom burden. And then here are the other diet surveys. So a MEDOS, which is a quick survey that people can do in about a minute or so, had good compliance. This ASA 24, which I have to admit is an extremely labor-intensive questionnaire, basically asking exactly what you ate for the past 24 hours, which I personally would not want to do. So it's not unexpected that we had a pretty low completion rate here. For subsequent studies, what I think we're going to have to do is actually have a person call and verbally discuss what the person had eaten over the past 24 hours, because this just doesn't seem like it works well. And then almost 100% dietitian visit. It makes sense that, if you're getting a free dietitian visit, you probably are going to show up for it. So then our next steps, we want to do a much larger study that is actually powered to detect whether a diet intervention reduces symptom burden in MPN. Our first studies just showed that this can be done, but now we want to know, does it actually impact something clinically in MPN? And potentially We could do some refinement of the diet, make an MPN-specific Mediterranean diet, potentially focusing on fiber and fermented foods, which the fermented foods may optimize the gut microbiome. So we're working on those and are making an attempt to obtain funding for a larger study. And so the acknowledgments, I want to thank a lot of people who were involved in these studies. Actually, the initiation of this study was with Robin Scherber, who I mentored when she was a fellow at Oregon Health and Science University, and we just continue to move this study on, along with her mentor, Ruben Mesa, as well as bioinformaticians at Mayo. And then at UC Irvine, this study was primarily led by a graduate student in my lab, Laura Mendez, who's now back in Mexico, her home country, as an MD PhD, as well as undergraduates in my lab, and Katrina Whiteson at UC Irvine, who is a microbiome specialist. So thank you.
Thank you, Dr. Fleischman. I think it's very important that you highlighted the New England Journal study that the Mediterranean diet does have an effect on cardiovascular risk and can reduce cardiovascular risk because, you know, whether or not MPN patients specifically would benefit, I think the correlation between MPNs and cardiovascular risk is very important to highlight, whether it be in the form of thrombosis, strokes, heart attacks. I think some of these interventions are very important to think about.